So you get to open with your opening remarks.
Good morning, everybody.
Good morning.
Good morning.
Thanks for being here on this November morning. Just by way of introduction, Mark asked me to sub in today. He's out of state. So I'm an HCAMN board member, and I'm also on the board for PNHP, Physicians for National Health Program. As far as my background, I have 25 years in practicing internal medicine in the private sector, and I have 10 years of practicing at the Minneapolis VA Medical Center. So I've seen it from both sides, both the private sector and the publicly funded, publicly administered, and also publicly delivered healthcare through the Minneapolis VA. So let me start out with a little bit of good news here. Mark asked me to tell you all about the resolution that was passed by the Los Angeles City Council. By a vote of 10-1, the City Council backed HR 1384, the Diapol resolution. So this is the biggest city in the United States that has thus far backed that resolution. So City Council resolution in Los Angeles passed. It's really good news that we're making headway in that area. Another bit of good news, and I think Don might speak to this a little bit later also, but for the next month, we have a match, a dollar for dollar match for a fundraiser for HCAMN. It's on the website. If you go to the website and click one-time contribution, there's a dollar for dollar match. So think about that. What other investment have you ever made where you immediately get 100% return on your investment? I mean, it's pretty good. And HCAMN, like any organization, needs money to function. You know, we need to expand our staff. We have a tremendous group of volunteers in HCAMN, but we could do so much more if we had staff, additional staff, to help us out. So, we're waiting for some volunteers of the quarter to appear, and we will defer that to later in the meeting. I want to also announce, Carol, have you passed that out?
Oh, I was waiting for the effect, but you're doing.
Oh, okay, good timing, Carol. So we have a very unique opportunity coming up on November 22nd. It's kind of a gift to us from the medical students at the University of Minnesota. They invited Dr. Adam Gaffney, who's the national president for Physicians for a National Health Program, to come and speak. So he's coming here free, a national speaker. He's written a book. He's been on, he's a blogger. He's been on Fox Business News. He's a very eloquent speaker, very knowledgeable, and he is going to give a public presentation November 22nd at the St. Paul Athletic Club at 7 p.m. So that's the St. Paul Athletic Club on Cedar. And there's going to be discounted parking. So we'll pass out vouchers where you can park for $5. So, you know, we're all members of the choir. You know, I like hearing you guys sing. But we need to bring in some other guys that are going to sing too. So volunteer to bring in other people, invite your friends, invite your neighbors that, you know, would like to learn a little bit more about this. They have some curiosity and they'd like to learn a little bit more about our efforts. We really need new people to get behind this effort. Okay, I'm actually a little bit ahead of time. And I just want to share with you, because I don't know when I'll ever get this opportunity again to speak for the whole quarterly meeting. I just have a special request for you all. I've been watching the impeachment hearings the last week and seeing what has happened in the past year, and I think we have more at stake in 2020 than a cause that's near and dear to our heart, which is single payer. I really think we have the republic at stake here. We are really, I think, in dangerous times. In a year from now, we'll know if we have a president that supports our cause of health justice by championing publicly funded, publicly administered, and single-payer health plan that is delivered through private hospitals, clinics, and healthcare professionals. But even more than that, we will know if we have a government that once again adheres to ethics and the rule of law. where truth is again sacred and where our government again imparts a feeling of pride in its citizens. You all are probably familiar with the story of Benjamin Franklin, that when he left the Constitutional Convention and he was approached by a group of citizens asking what kind of government the delegates came up with, and his response was, a republic, if you can keep it. And I think we're at that point right now. Can we keep the republic that we currently have? I'm greatly concerned about that because of the rampant corruption that we're seeing. Numerous officials and aides of the current administration have pled guilty or been tried and convicted of various crimes, including one yesterday who's going to be serving a prison sentence. I am concerned about the functioning of the separation of the powers and maintenance of co-equal branches of government. I'm concerned about the future of our country when the phrase used by dictators is repeatedly stated that the press is the enemy of the people, in direct contrast to the First Amendment to our Constitution. But I'm optimistic that we can reverse this dangerous course. I think that there are hundreds of thousands of Minnesotans and millions of Americans that still have the capability of thinking for themselves, that seek the truth and desire to make decisions based on facts that are borne out by evidence. So I'm asking you to join me. I'm committing for 2020 to restore the lawful functioning of our democracy by working on the 2020 campaign to elect ethical, progressive candidates. And we've probably done that in the past, all of us, but I think this election year we need to step it up. We need to step it up. So my plea for you is to make a similar commitment to mine in the year 2020. I know we're a group of passionate, dedicated activists, and we need to dedicate ourselves to the electoral campaigns of candidates that are likewise committed to the health justice we seek and the government we so desperately need. Please get involved in talking to your friends, your family, and neighbors, and provide some education to them about the truth with all the misinformation that's currently out there. Also, please get involved in campaigns by door knocking, which I intend to do, phone banking, or helping in any other way that you can with these campaigns, because this is a very critical year and we need to reverse what's going on here lately. So, I'm 5 minutes early. Thank you all. I got 2 questions.
Yeah, I couldn't agree more. But back to Gaffney, do we know where else he's going to be speaking for people who might be can't make it?
Sure, that's a good point. Thank you for raising that. And okay, let me start out. He comes. Actually, he's going to be staying at our house. So, so Thursday. Okay. I'll do what I can, and then if you want to supplement, or do you want to tell me what's going to happen? Okay. So the first thing he's going to do is he's going to be at internal medicine grand rounds at HCMC. I think it starts at 12:15, but it's over the noon hour on Thursday, the 21st. And then that evening, he's going to be at the University of Minnesota with the medical students. That's the event they invited him to. So the idea is to have people who are involved in economics, in public health, and in medicine, and nursing students. And there's going to be like 4 TED Talks delivered by the students, and then the keynote address is going to be by Dr. Gaffney after the students give their TED Talks. So that's the evening of November 21st. Does it start at 5:30, I think? 5:30.
No, the next 2 are, it's like Friday.
Okay, yeah, and then so.
Is that open to the public?
I don't think that the Thursday events are open to the public because the HCMC one is, for internal medicine grand rounds of staff.
Some of us might have status.
Some of us have more status than others, right?
But there's one on Friday that is open and we need more attendance.
Dr. Tom Henry, who's a neurologist at the University of Minnesota and goes to our church, was able to get a free event for any professional at 2 o'clock at the U of M at the Cardiovascular and Cancer Research Center. I can't remember what address the street is. It's posted on the November 22nd calendar and the pnhb.org. That one is free. It's right across the street from TCF Stadium. It's right across the street from there. And there's a capacity for 125, but yes, you can go to that one if you can't make the 7 o'clock one. That will be more geared to our healthcare professional, where it's a nurse practitioner, a doctor, a nurse, PharmD. That will be more geared towards them. And then the 7 o'clock at St. Paul Athletic Club, we have capacity for 400 in that ballroom. And it's amazing. What I tell people when I go around and talk to them personally, and really the best way to get people out is talk to them personally. Talk to your neighbor, make a phone call, talk to your friends and family. This is what we need to do. And I ask them, have you heard about all the talk about healthcare coverage right now? Unless you're hiding under a rock, you've heard something. And I say, this is your opportunity to hear the truth from one of the best speakers I've ever heard. Of course, you can't say that if you haven't heard him. Go listen to Fox News or even Joseph here. But say your plea that way. He's very dynamic, he's very informed, he's coming to St. Paul, he's a keynote type speaker for free. This is the event, come with me. I'm riding the car, come with me. This is the time, 7 p.m., it's a really easy place to find. We have reduced parking, it's right off the light rail. But I tell them this because, you know, there's all this going on, and Cheryl and I went to the Skywalks. We were actually got 75 people to take a flyer and at least consider coming. Some of them committed right away. Because Skyways are free public venues. So if you want to take some of these flyers and go out to Minneapolis or St. Paul Skyways in the next few days, please, you're welcome. Monday when more people are at work. That is a way to get people that's almost better on the side than on the sidewalk, because that's where people are working and it's inside and we can invite them. But the most effective way is just people you know. Share what we put on Facebook at PNHP or HCAMN or my own personal page. And get people out, but also follow it up with a telephone call. Did you see this? Can you come? This is near and dear to my heart because if you have a personal story you can tell for 1 minute about a family member or somebody you knew, it really helps. We should have a lot of different supportive groups. But, you know, sometimes we advertise it through all sorts of unions and venues and everything, but it's mainly just that personal invitation. So at 7 p.m., St. Paul Athletic Club, 340 Cedar Street in St. Paul. It's free and open to the public. But for that event, we are only providing water. I have to bring chicken wings over to Mad Dad's personally because he wanted chicken wings for everybody.
Thanks, Carol. So again, the challenge is to fill the ballroom, which has a capacity of 400 people. So please invite friends and everybody you can. Okay, so Don is next. Did you want?
And I'll cue you when David. Okay, I forgot to introduce myself. I kind of assume everybody knows who I am, but it's Ann Jones, and I'm also on the Board of Healthcare for all Minnesota. And coming up is Don Kilkenin, who is board member as well, and liaison with the legislative committee. He's going to give you the money talk, like in church. Okay.
Well, thanks, Kenneth Carroll, for your very inspiring opening to today's meeting and announcing another great meeting coming up with Dr. Gaffney. And all the work that we're doing, of course, needs money, and that's why I'm standing before you this morning. As treasurer, I'm pleased to report that our funding is now raised to $18,744. Thanks in part to an anonymous donation of $5,000 that came about last July, and that $5,000 was doubled to $10,000 by mid-October, and that was through, of course, smaller matching donations to match that $5,000 to bring it up to $10,000, and the HCAMN Development Committee has found another anonymous donor who is offering another $5,000 in matching money. So you all and other folks now have the opportunity to double that $5,000 to a second $10,000 by the end of this year. Just go to the HCAM new page on the HCAM website and the donor page, and you'll see that you'll have a very engaging giving experience that even Ebenezer Scrooge couldn't resist. And the money helps to give the gift to Minnesotans that need health care. And it'll help deliver our message by November of 2020 to every voter. And we also, to keep our work going, we need sustaining effort. So as you're contemplating going on to the donor page, please consider being a sustaining donor. Thank you.
Looks like on our website. There is an and you can pay by looks like there's a credit card option. There's also a spot where you could make a monthly contribution if you wanted to give a smaller amount monthly, if that's more comfortable. And if you do want to make a tax deductible contribution, you would have to send it in by check and indicate co-op education fund, correct? To make a tax deductible. Okay. And I see that our speaker is here. I was next up on the agenda is a report on, some of us have been to two big national meetings. I went to the one in Portland, Oregon, which is a single payer strategy conference and the labor campaign for single payer. And Rose was there, with also a number of people from MNA here in Minnesota. Kenneth Carroll and Rose also went to the PNHP annual meeting and leadership conference, which you'll hear about a little bit later. So let me just give you the flavor of this conference. It was here in Minnesota last year in June, and Oregon has a very active state-based plan, I guess, organization. They've been working on it for quite a while. Gary and Steve are very big on Oregon's work for their state-based health plan. So this event was held in the city of Portland in downtown at the Unitarian Church, where we got a video welcome from Representative Jaya Paul, who is the lead author of the HR 1384, which is the newly rewritten, was the old Con-Use bill, now HR 1384 aligns really well with our Minnesota health plan proposal and would be the counterpart to the Senate bill, which is 1189. And I've got a handout on the back, in the back of the room, that talks about all the terminology swirling around about a national health plan or a state-based health plan, and the dual track for a state-based plan and national plan. So please pick that up and get familiar with that as we go forward into the election year of 2020. That's Friday evening. Our opening speaker was our own Rose Roach, was the keynote speaker, and then Sarah Nelson, who's the president of International Flight Attendants Union, as a example of labor's commitment to this issue. She gave a pretty fiery talk as well. This is a list. If you go to the website called, I know you're hearing a lot in the during the debates right now about how we can't really, change now because labor's made such a big contribution, a big commitment to their health plans as their part of their benefit package. But I would beg to differ. If you take a look at the Labor Campaign for Single Payers homepage, you'll see a number of large unions who've made a commitment to a national health plan. And I've heard recently that there's a little bit of backsliding on that, but we are still, of course, working to go forward with this. So another speaker was Richard Master, who's been such a huge contributor to our knowledge base and support and tools that we have to educate the public about a state-based or a national health plan. Richard Master, he is the creator of the Fix It series, and on the back of our one-page summary landscape of the current healthcare payment system, on the back of that is the website for the Fix It series. You can literally pull up these videos, and we're going to show one a little bit later on this morning. So he was a speaker, very big champion for this. Also has formed what's called the Business Initiative for Health Policy, working on really some high-powered names at the national level in support of this effort. Alex Lawson spoke, Social Security Works. If you haven't read or go and look up Social Security Works, and talks about how powerful Social Security and Medicare are and how important they are to our social safety net. And there's actually a book called Social Security Works that talks about how powerful Social Security is for security for our seniors. And he is also you can sign up to get messages from them by email, of course. The location for the conference was a Unitarian church. Like I said, that was the only glimpse of sun in the whole 4 days that I was in Portland. And so many choices for the breakouts. There was a labor campaign keeping union members on board. PNHP was there, with single payer in the news, municipal resolutions, coalition building, the one-payer states, of which Minnesota is a member of the one-payer states organization of about 17 states or so who are working on state-based plans. Breakouts on paying for single payer, partnering with business, taking on pharmaceutical industry, a just transition for workers. There was more than anybody could attend, of course. Building a feminist, multiracial, pro-immigrant, accessible movement, base building, opposition research, crafting a strategy to win, a video interview with a Canadian physician, and also some information about the congressional hearings that have happened over the last few months. Distributed organizing presented by the National Nurses Union. I know, Carla, you've been part of work on that, barnstorming and phone calls and door knocking. That will ramp up, of course, as a national health plan moves forward. And then Sunday finished up with a talk about bringing all voices to the table. Because I mean, look around at us, we're all pretty lily white in here, and we all know we need to be reaching out a little bit more to communities of color. I went to the base building one in particular because, as you've heard me say many times, our power is going to be in numbers. Base building is the 80% of our work, and along with that, educating the public, but we need numbers. And then the evening session was the One Pair States organization that I went to, and they've got a project going called Values-Based Communication Strategies, and countering an opposition who will use fear, uncertainty, and doubt to hold us back. So that communications working group is working on messaging and framing, and then also discuss some winning opportunities such as multi-state drug pricing proposals. So there is some work to be done along the way toward the moonshot that we want. Also introduced something I didn't know much about, was the state-based universal healthcare legislation. I hope that you all got our call to action that we sent out right after this conference, asking you to talk to your representatives about becoming an original co-sponsor for something called the State-Based Universal Healthcare Act of 2019. It now has a number. We have one representative, Ilhan Omar, who is signed on as a result of our efforts in contacting her in her office. But it is enabling legislation for a state-based bill. You've probably all heard about the 1332 waiver that's in the Affordable Care Act. In order for states to get permission to have a state-based plan of their own, it has to be as good as or better than what the benefits offered with the ACA. Requires a waiver. We're pretty sure this administration is not going to grant any waivers of that sort. But this is enabling legislation that would bypass that requirement. So you got an action alert, and now there's still time to ask representatives to sign on to that. And more on that after our speaker. And I need to ask, I have scheduled in a break, but I see that Dr. Schondelmeyer is here. Would you like to start?
I need a cup of coffee too.
You need a cup of coffee too, okay. And then in that case, I would invite you to take a quick break and stop by our action tables in the back. Consider buying a a t-shirt. Pick up some postcards for writing to your representatives. I know you just kind of sat down, but we're going to take a break now because it kind of works out for the whole rest of the morning. Pick up the Commitment to Act forms, pick up the postcards, pick up business cards, and as I'm going to echo what Ken said, consider working on campaigns. This cycle is going to be really important for a lot of reasons. So refresh your coffee, and then we'll get set up for Dr. Schondelmeyer.
Oh gosh. Against what we stand for.
Loving girlfriend is never rude.
Is this working? Yeah, this is sort of working. Can everybody rejoin? Class is starting. We're going to vary the agenda just slightly while Dr. Schondelmeyer is getting ready. We're going to talk a little bit more about the state-based universal health care bill, the bill that would enable us to do a Minnesota health plan. So this is a bill that I guess has been introduced a couple of times before. I didn't know anything about it, but it's reintroduced by Representative Grocon of the One Payer States organization is very interested in getting more sponsors and moving this forward. It meets the requirements for a waiver to the Patient Protection and Affordable Care Act of 2010 for states to implement by providing several federal funding streams, such as Medicare, Medicaid, CHIP, all the big money we would need to make a state-based health fund work. The action alert that was sent in October that you got was for original co-sponsors, but going forward we would like more House co-sponsors. So Linda and Greg Gridley have prepared some information to talk about a project they have started in CD4, and we will want to invite our East Metro group to join that work. And then similar work will be going on in CD3 with a goal to add CD2. This was just what the action alert looked like, just in case you need a reminder. And there is we still want people to be contacting their representatives to get them signed on to this. This is the list of reps who are currently signed on. You can see we have quite a ways to go. Linda and Greg, come on up. So I might need help. Thank you. This is taking off on the grassroots organizing training materials that are on the Healthcare Now website. It has become quite apparent that it isn't going to work to have 2 or 3 of us talk to each one of these representatives and say, hey, we want you to do this. They're going to have to hear it on our
So we have a committee of about 8 people, and what we're going to work on is Betty McCollum to get her to sign on to Medicare for All. Currently, we did watch the video, the healthcare video, so we are using their outline to attack Betty, if you will. It actually started this summer when Ann and I and 2 other women went to Betty McCollum's office and spoke to her constituent advocate. And we did leave her with a lot of information and some personal stories. But also in attending a couple of her town halls, she's been asked where she stands on Medicare for all, and every time she has said she's for Medicaid for all. And so we looked and looked and looked to see what that was, couldn't really find anything that was of any help to any of us. So where we're at right now, we've had 2 meetings, we're about to have a 3rd meeting, and well, we also have one more thing that I have to throw in. We also have a gentleman who has is going to run as a Democrat against Betty McCollum, and his platform is single payer Medicare for all. His name is David Sandbeck. You can look him up at sandbeckforcongress.com. He's really fierce about it. At the Bernie rally, he stood outside and got people to sign up. So where we're at right now, we, according to the plan, we did look at her donors on Open Secrets, but we didn't see anything that really called attention to why she wouldn't be for Medicare for all. However, in looking at all of this, we realized she is the regional chairwoman for the DCCC, and we know that the DCCC is the fundraising arm of the House, is not for Medicare for all. We also looked at other donors to her. We have 9 unions. We found that 3 were for Medicare for all. We did contact the other 6. We've heard back from one of them, and we will stay on contacting them. We also got a list of her caucus delegates from her district. So we're gonna start phone banking this list. And what we will do is we're working on a petition, so when we talk to these people, we'll try to get as much information on them as they will give us for contact. And then we will direct them to the website that will have the petition that they can sign to sign on to Medicare for all. And we also have a list of medical professionals that we will also be phone banking and getting them to possibly do the same thing. And then as we proceed with this, we will, if she isn't very easily moved, we will continue to escalate our process by standing outside of her office. We can do die-ins in front of her office. The one problem with where she is she's like a block, she's in an industrial area just off University by 280. And so you stand on University Avenue and it's really not apparent where her office is. But we're still confident that we can get her to move. We also have spoken to someone that worked in her office, and he gave us a little bit of feedback. He says she's not very good at fundraising, so I don't know how it is then that she's the regional chair for the DCCC. But he did think that it was maybe possible to move her. And she is for, she actually was her constituent representative in her office here said that she was on House Bill HR 1277, which was introduced, sorry, Greg, which was introduced on Valentine's Day last year. But it's not,
that's the Medicaid problem.
Right. It's Medicaid problem.
Is that a subsidized plan?
It's basically just a public option, you know, where they can buy into Medicaid.
With their own money?
Yeah. Yeah, so it's not for everybody, you know, it's not a.
And I'll tell you what I think we should do is start a draft Erin Murphy's plan. We don't need her in the state senate, but we could use her in Congress.
And that's one of the things that David was actually trying to get her to run, but she wouldn't do it, so he's running.
We're gonna also have a town hall meeting and invite her to it.
Yeah, state senator.
No, I'm serious though, we should, somebody get back there and say, for the good of the order.
She's already running.
Well, now she's running again.
She's running for state senator.
State senate.
Against
Yeah.
Dick Cohen.
Dick Cohen, yes. What do you think?
Right.
Me too.
I mean, there's no competition for me. Dick needs to retire. Yeah, he's been there a while. He's an old fart. Not that old farts aren't good.
Very much for humanitarian efforts, and so we're hoping that this will somehow. She's not a lost cause.
Did you go to the meeting at their house? No, did you? No. There's one too many meetings that week.
But anybody that wants to help us is more than welcome. Yes?
How often does she have phone calls?
How often?
Yeah.
She's had them pretty much during when they have the recesses. She does. And she's pretty good about communicating.
About a month ago, she had one out at Stillwater that was pretty
Yes.
good, but she would not support Medicare for all.
No, we had friends that asked her.
And it's like, I know Joel was there and was very eloquent,
Yeah.
and she backed right out of it and supported.
Well, we think her relationship to the DCCC might be what's.
She says that this one she thinks can be passed easier.
Yeah.
That's what she says, why she supports this Medicaid.
You recognize, I'm sure, that Betty is gonna go with the status quo, whatever the Democrats want.
Right.
It's not that we're gonna get to her, we have to get to Pelosi or whoever. She's not making this decision on her own, I'm sure.
Well, and that's our concern, that she's with the DCCC. That is our concern, because she's with the DCCC. She's the chairwoman for the region for the DCCC, and they absolutely are not for Medicare for all. But this healthcare video that we watched, they moved at Markey with this escalating tactics. And also, who's Jeffries?
Yeah,
Hakeem Jeffries, his constituents moved him. Yep.
She's having a forum this morning. You all know that. She's over there talking about, Medicaid. I'm trying to think of the name, but it's over in Senate District 53, I believe. Having a forum today.
Betty?
Right now.
Yeah,
I did not
Medicaid
know
for
that.
all. That's her thing.
And it's not John Marty's bill by any means.
It's some bill where you can buy it.
We did talk to
Seems
John
like
Marty at.
It's not Medicaid then, yeah.
St. Joan of Arc,
Medicaid.
and he was.
Yeah, so it's like a buy-in, but a different name.
Can he tell that she didn't?
I mean, it's right there, I guess.
I actually think we can move. I'm gonna go with that. We're gonna
I think
just
she
do
has to be
it.
convinced that there's a majority of people
Yes.
that really want it, but people are so confused that they can throw out all these different plans and they think, oh, they are supporting it, but they're not really, because there's all these plans that have the same name similar to it, and people are confused by it, so they think, oh, she's supporting a Medicare for all plan.
He's
But
in
it
our
isn't,
district.
it's not, that's
I
the
couldn't
problem.
get through.
And so then she can satisfy, they put out that plan, and the majority of her constituents say, oh, that's good enough. So they're happy that she's supporting something for the healthcare.
But if anybody else wants to join with our making phone calls to our two lists.
And your meeting, your next meeting is the 19th at?
Yeah, if you give me your email address, I can send you the location. It's in a house.
Thank you so much. This is great activism. And Dave, would you come up and kind of give a little description of activism going on in CD3?
Good morning. Of course, you probably heard before, we've been working on Congressman Dean Phillips, who is campaigned against Medicare for all. He never did like it. And so we've been trying to meet with him over the summer, and got 2 meetings with his staff. And each time we had a meeting, he had a town hall shortly afterward and doubled down smearing Medicare for all. So it was pretty disappointing, to say the least.
So he's got a meeting coming up next Saturday. And we are going to flyer outside of his meeting everybody that's coming in, and we wrote a little thing. I'll read part of it for you. Healthcare for All Minnesota and Physicians for a National Health Program. I hope you, Ken, is that okay to put your name in there? Okay. Would like to meet with Congressman Dean Phillips to address the misconceptions he has expressed about Medicare for All. Thus far, he has declined our invitations to meet with us directly to address his concerns and answer his questions. The following is a small sampling of statements he made at his town hall followed by our rebuttals. Please call Congressman Phillips and ask him to meet with our group. And I gave his phone number. So here's his first statement. It's time we make a moral decision to ensure that every single American has access to high quality care at a price they can afford. That was okay. So we said we agree. Other countries around the world have demonstrated that publicly funded healthcare systems lead to improved health outcomes and lower costs. Now we get into the next, where he starts drifting. We have got to let Americans make the choice. Notice that word, always comes up. By offering the program that you are talking about, well, not really when you hear the rest of this, whether it's Medicare or Medicaid buy-ins, and there's a lot of propositions and more being worked on at this very moment. I believe if we want to achieve what I want, we have got to do so in this way. Let Americans choose. This is a land of freedom and liberty. So then we came back with the choices that people care about are the doctors and hospitals that they choose, as well as the quality of their coverage. Medicare for All has no restrictive networks like private insurance plans. You see whatever doctor or go to whatever hospital or clinic you choose, trying to get back to his choose and choice, anywhere in the country. It also has more comprehensive coverage than any other plan that exists today or has been proposed. A public option or buy-in will do little to make care more affordable and address profiteering and administrative waste. The risk pool needs to be shared, and this can only be done by eliminating the middleman, aka insurance companies. Only a unified single-payer system will reduce administrative costs, eliminate insurance premiums and out-of-pocket costs, and have negotiating authority to ensure reasonable drug and provider pricing. Only a publicly funded and privately administrated plan can reduce costs and still provide choice of care. Choice again. Multiple studies include one funded by the Koch brothers have demonstrated the cost savings that a single-payer health plan would have for our country. Over 200 economists sent a letter to Congress in May endorsing Medicare for All single-payer system. One of the economists expressed it this way: Medicare for All will give us a system already proven in other countries, much lower costs with less hassle and worry. It's a sure winner, except for the profiteers. So we added a few more things. We're hitting on this freedom and liberty here. So HCAMN says freedom and liberty means not to have to worry about whether or not you can see a healthcare provider, pay for your care, or have to ration your care or medicine to avoid going bankrupt because you become ill. Freedom and liberty is knowing that all of the health care that you may need will be covered regardless of your financial situation. That means paying a fair premium or tax based on your ability to pay into a fund that exists solely to promote your well-being versus to insurance companies that are concerned only with making profits. Freedom and liberty means being able to see the provider you choose and have healthcare decisions made between you and your provider, and not an insurance bureaucrat with the goal of making a profit. Freedom and liberty means having health care while you explore your dreams and use your creativity as a self-employed individual or small business owner versus having to take a job to get employer-based health care because the market plans are too expensive. Freedom and liberty is being a small business owner with the ability to innovate and grow your business instead of spending resources on managing and implementing health care for your employees. With a single payer system, you would simply pay a predictable, affordable employer tax to support a fair, publicly funded health care system. And that's what we're going to pass out.
And Representative Dean Phillips' next town hall is the 23rd of November.
At 2 o'clock in Brooklyn Park.
Okay.
And we would love that if there's anybody who wants to show up and help
with flyering.
What's the location? Brooklyn Park, what's the exact location?
It's
Technical Community College.
Hennepin Technical College.
It's 9000 Brooklyn Boulevard.
Okay. And then your plan is also to petition, to ask people to sign petitions. So got some activism going on in CD3.
Okay, the next part of our program, before I introduce Dr. Schondelmeyer, is awarding activists of the quarter. And before I do that, and before I forget, if any of you would wish to nominate anybody from HCAMN as a volunteer of the quarter, please do so. Submit the name to Ann Jones or Dr. Mark Rocky, please. We welcome any nominations that you have. So, this quarter, we actually have 3 volunteers of the quarter, and they have a lot in common, much to the chagrin of Dean Phillips in CD3. They are healthcare payment reform activists and volunteers, and they've recently established a new chapter. It's great, we got a new chapter in the West Metro. They also go to town halls, as one of them just mentioned, and they have done some other individual things that I'm going to mention when I call them out. So, I think in the interest of efficiency, let's call up the 3 volunteers of the quarter. They are Linda Hartman, and Dave and Roseanne Garibaldi. So Linda's, I think, going to make it up here first. And I've mentioned some things about her. I should also mention that she organized a presentation in Maple Grove, works with the West Metro group. Linda also arranged a radio interview on AM 950 for Rose Roach, the M&A executive. And all 3 of these people have held up signs at Dean Phillips town halls saying true, false, or misleading as far as his statements are concerned. So, you know, one of our jobs is to get the right people in office, but then the second half of our job is, once they get in office, is hold them accountable. And these three are exemplary in that regard. Okay, so let me say that for Dave and Roseanne, I mentioned a lot of things that they share in common. They work with the Indivisible group and arranged for a presentation in the North Metro, coordinating that with the Indivisible group. And then they organized a meeting with staffers to challenge and inform about Medicare for all and single payer. So could I just read what that says? So what it says here on Volunteer of the Quarter: in recognition and gratitude for your outstanding contributions to the mission and vision of healthcare for all Minnesota, and it's signed by Dr. Brocky. So congratulations.
And we're going to get, I believe we're going to be able to get the interview that Rose did on AM 950 up on our website. Stuart, is that possible to get radio interviews up on websites? I don't know these things. So anyway, it was very good, and Rose did an awesome job, and it's Brett Johnson mentioned Healthcare for All Minnesota 4 times, I think, during that interview, but Linda got that for her.
Can we play other people's
Serious
This is the one we almost never use.
So my prediction is that at the end of Dean Phillips' first term in office, he's probably going to have about the same amount of hair I do on my head. Because of those folks. Okay, I'm going to go ahead then and introduce Dr. Stephen Schondelmeyer. He's our guest speaker, and I have to say, these quarterly meetings have been so good because I've learned so much from every one of them. I really enjoy them, and one of the reasons is Dr. Schondelmeyer here to speak with and inform us. His topic is the high cost of pharmaceuticals in the U.S. He's a professor of pharmaceutical economics in the College of Pharmacy at the University of Minnesota, where he holds the Century Mortar Club Endowed Chair in Pharmaceutical Management and Economics. Dr. Schondelmeyer is the director of the Prime Institute, that's all capital letters, P-R-I-M-E. The Prime Institute focuses on pharmaceutical research related to management and economics. He also serves as head of the Department of Pharmaceutical Care and Health Systems and sits on the Minnesota Attorney General's Committee on Drug Prices. So please, let's give Dr. Schondelmeyer a warm welcome to the quarterly meeting.
As he's working to fine-tune his slides, and we're going to load them and bring them up. All right, hot off the presses.
I get to work with Steve on the Attorney General's Lowering Pharmaceutical Task Force. I can tell you, this guy is brilliant. You're going to love this. I learn from him every time we do something together. Hi, Steve. Welcome.
First, I would tell you, I'm not here to sell you anything. I'm not here to ask for any votes. I'm here to help us understand what goes on in the pharmaceutical marketplace. I'm a pharmacist. I'm a healthcare economist. I have degrees in public policy as well, and I've studied the pharmaceutical market for 45 years. I have databases that list every drug that's been on the market from 1980 to the present and their prices. I know who's naughty and nice in terms of prices. And I've studied the patterns. And what I must tell you is there are no simple solutions for the pharmaceutical problems, but we can and are making progress. Pharmaceuticals are much like that proverbial balloon. And you squeeze here, it bulges out here, or here, or here. And often we find new places that it bulges out. That's not right.
That's not the right one, okay. No problem, we can just start over again.
Maybe I got the one for mine.
Okay, yeah. Because that's the one that comes up on the page.
All right, let me go switch it over on. I can make that one. No. The other.
Okay, I'm going to do just to create some space here. I'm going to just go ahead and delete it.
So Rouge, you do a song and dance real quick. Then
All right.
All file copies.
So one of the trainings that took place over in Portland at the National Strategy Convention was on Friday, and it was actually geared towards those of us in the labor movement. And it was kind of a trial balloon to see how this training worked in talking with workers directly and labor unionists in particular about why they should be on board with Medicare for All. And the training is called Runaway Inequality. It's based on a book of the same name, and it was just such a great way to sit and look at how we as workers have been handing over our wealth to big pharma and insurance companies, for the most part, for the last 40, 50, 60 years through this product called health insurance as a supposed benefit, right, as a worker. And the training was phenomenal. It was a great way to really look at the issue and take, in a way that was just different than the way we usually talk about it. And I'm going to go ahead and become a trainer on that particular program so that I can do it here in Minnesota and offer it. And I'll make sure that you guys all get an option to be some of the first participants if you're interested. Oh, they're right there, Steve. So, but that was a really good training. Yeah, definitely worth it. All right, let's see if we can. Oh. Oh, it's right here, so I think, no, I took it, yeah. All right, we're up and running.
My garage door opener is easier than this. Pharmaceutical Genomics, as I was telling you, I've done this for a long time. I've seen many, many things happen. I've seen things look like we're making progress and then we backtrack many steps. Yeah, I'll save for the end. I'm going to ask you a couple of questions that I often ask audiences, ask my students, ask patients, other groups. First, I want to know, is there anybody here that's never been sick a day in your life? Raise your hand. No, go ahead and raise your hand. Okay. Is there anybody here that has not needed or used a prescription drug ever in your life? Raise your hand, let me see. Don't be shy now. Okay, and why do I ask you these simple questions? The point is, there's a universal demand for healthcare and prescription drugs. Everyone needs, has needed, or will need prescription drugs in their lifetime. So we're not talking about something in society that's a preference good. I want a big screen TV that's 55 inches, or one that's 65 inches, or one that's 70. No, you can actually listen to the radio. You can actually watch a smaller TV. You don't even need a TV. Prescription drugs, though, are something that aren't just a preference good. These aren't they're not even a normal commodity in society. These are different economically than other things we deal with in our marketplace and in the economy. So prescription drugs are a necessity. Healthcare is a necessity. Because of that, the economics of healthcare and prescription drugs aren't normal. They don't work like normal economic principles would. I believe it. I'm an economist. I believe in economics. I believe in markets. I believe in the westernized way that markets work. But fundamentally, healthcare will never be a normal market, and prescription drugs will never be a normal market. And that's structurally, that's true. It's true for a lot of other reasons. I like to tell people you know, one of the proponents of a version of Medicare for All is Bernie Sanders. Now, Bernie Sanders had an encounter with the healthcare system recently. Okay, now I want to illustrate this economics point this way. And I'm not picking on Bernie Sanders, but do you think when he had his heart attack, he was rolling into the emergency room on the gurney? Did he sit up and say, but wait, how much will this cost? And if there was anybody who would do that, it would be Bernie Sanders. Okay? But I don't think even then he did. My point is, we don't make very rational decisions economically when we're faced with life and death. When we're rolling into that emergency room to be revived from a heart attack, it isn't about what is the cost of this. It's about, I need that, and we have the technology to do that, and how do we deliver that efficiently to people and make it available, not just to the ones who have big bank accounts, but to everyone in society. How do we make that universally available? So, first point I'd make is healthcare has a universal demand. That makes it, I would argue, a public good. In economics, we have a term, public good, as a certain set of transactions that are different from others because they have universal demand, they're about life and death, they're necessities, and if anything ever fit the public good category, it's healthcare and pharmaceuticals. So I think in your language, in your discussion, policy-wise, point out, healthcare is a public good. It's different than other things. It's not a preference good. It's not a choice good. I heard that term several times this morning in a disparaging way, because choice, I'm not against choice. Choice is a good thing, but not in the context of healthcare where you have to have it. You need to have a reliable system and have it available. Now, the next thing I want to point out to you, who's the guy that had the signs? True, false, misleading? All up misleading. So often you'll hear people, and some of the nation's best economists and healthcare economists will make these mistakes. Now I'm going to show you the nation's healthcare dollar. On the one hand, it is accurate, but people misinterpret it. And so first, in 2018, how much did we spend on healthcare? Well, it was $3.65 trillion. Now, how many zeros are in a trillion? It's like 12, okay? It's a lot of zeros. And this is the nation's healthcare pie, and these are the numbers from the Office of the Actuary, and I actually worked with that at times to estimate pieces of this. And overall, this is accurate, but people misunderstand and misuse this in a way that's very misleading. So first, look at it. What are the largest pieces of the pie? Hospital care, physician services, and then we get down to number 3, which is prescription drugs. It says prescription drugs 9.4%. Now, the first thing that people don't read or understand about this pie, they say, well, prescription drugs are less than 10% of the healthcare dollar. Why are you worried about prescription drug prices? Yeah, so prescription drugs, this is accurate for prescription drugs, and if you read the definition of the Office of the Actuary, they say this is only outpatient retail prescription drugs, like the drugs you get at Walgreens, CVS, and Steve's Corner Drugstore. This doesn't include drugs in other pieces of the pie. Are drugs used in other sectors up here? Well, yes. In fact, they're used in every other sector up here. And yes, in fact, if we estimated the amount spent on drugs in all of those other sectors, we'll find out that prescription drugs, instead of being 9.4% of the pie, are actually about 20.5% of the pie. Drugs are, now let's see if we, and remember that reduces the size of the other pieces a little bit too. If we account for drugs fully and completely, they're the second largest piece of the pie. In fact, today we spend more on prescription drugs than we do on physician services. Let me say that again. We spend more on prescription drugs than we do on physician services in the healthcare system. And I'm not saying this is good or bad, but first let's start with the facts. So now you can hold it true, okay? Drugs are a bigger piece of the pie than most people give it credit for, And what they do is they'll focus on the 9.4% and say, that really hasn't been growing a lot lately. Well, that's largely 90% of the retail outpatient drugs are generics. So they're looking at generics. It's true, generics haven't been growing as fast as brand names. But the new drugs on the market are dispensed in hospitals, they're administered in physicians' offices, they're dispensed through specialty pharmacies, which aren't fully up here. They're dispensed in other places, but not in the corner drugstore. So drugs have been growing very rapidly. They're the fastest growing piece of our healthcare pie still. But the drug growth has been in the other pieces of the pie, not in the prescription drug piece that's identified up here. So again, this chart is often, it is accurate if you read the definitions, but people don't read. Okay? Legislators don't read. Policymakers don't read. You have to point it out to them that they really are looking at misleading facts in terms of prescription drugs and their role. So really, this is the question. Now, we laugh at this, but many times when I go to the doctor's office, you know, the nurse will come in and prepare you and ask questions and get all ready for the doc to come in and check you out. And then after the doc's been in, you're left sitting in the room, and you're sitting there thinking, how sick am I in dollars and cents? Is the doc going to give me a prescription? How much is it going to cost me? Can I afford to get out of here today? And many patients, most of us probably ask that question thinking about how much will my copay be. But there are people who don't have insurance who are thinking, how much will this prescription cost? Can I even afford it in the first place? How am I going to get that medication? And like I tell my pharmacy students, a drug that is carefully prescribed by the physician for the patient, and the patient is counseled by the pharmacist and the nurse about the drug and how to use it, but the patient doesn't get better by staring at the drug on the shelf in the pharmacy. Unless you can afford it and actually have the drug and take it, use it properly, your health doesn't change. So just because we have innovation and new drugs on the market, and wonderful drugs, and I applaud the industry for finding some new therapeutic advances, but just because it's on the market doesn't mean it changes my outcome. We have a health system that produces some of the best healthcare in the world if you can afford it. But we have a society who hasn't bothered with helping people afford it. And that's what you're all about, I think, is helping people afford the health care that we do have, that we have produced. I want to real quickly, I like to use real data. I'm from Missouri originally, the show me state. You know, show me. Real data and the U-Plan experience. I help manage the university's health benefit. We have 40,000 covered lives. We're a self-insured employer. And just quickly, this is data from 2004 through spring of this year. How much did the average brand name cost? Now, the first thing I ask my students is, do you notice a trend line here? Do I have to point that out? Second, what's the cost for a 1-month supply of a patented brand name drug? It's $860. Now, most patented brand names, not all, but about 80% of them are chronic meds. It means you take it all year long. If you had to take this all year long, how much are we talking about? Okay, so 860 times 12, we're up around, what, 90,000 something a year for one medication, or 9,000 a year for one medication, $9,000 to $10,000. Again, if you were prescribed this medication and had to pay for a year's worth today, could you just whip out your pocketbook and pay for that? You have, I'm not, don't raise your hands, don't want any HIPAA violations, but most people would struggle with that if they had to pay cash out of pocket for that. That's a lot of money. And the average senior uses not one chronic med, but 4 or 5 chronic meds a year. So we're talking about expenditures upwards of $35,000, $40,000 or more per year just for prescription drugs. That doesn't include rent and food and utilities and clothing and other things. That's just for prescription drugs. Now, There are off-patent brands. This is the patented brand after generics into the market, and the brand stays in the market. And notice it actually has flattened out a little bit in the last 2 or 3 years. They're only $360 for a 1-month supply, or again, if we annualize that, we're up around $4,000 to $5,000 a year for the patented brand. And then, fortunately, in the market, there are these things called generic drugs. The average generic prescription is $37 for a 1-month supply. That means the annualized cost of that generic is about $500 for a year. So for a year, you can get a generic medication for the price, less than the price of a 1-month supply of the patented brand. A substantial difference. And at the university, we very selectively, and I won't spend a lot of time on this, but we cover certain over-the-counter products that actually cost equal or less than brand name substitutes that the patient might ask for. You know, if you're buying the over-the-counter product at the drugstore and it's costing you $35, $40, and then you think, now my copay on brands is only $10. I'm going to ask my doctor if he can prescribe a brand name so I don't have to pay $35 at the drugstore. And then the doc prescribes something that ends up being an $800 prescription. It costs us more. So not all OTCs, but we selectively cover certain over-the-counter products because they are good quality and safe and effective products, and they help us use the resources much more wisely as a university. What percent of all prescriptions fall in these? Brands are 9%, off-patent brands are 2%, the generics are 83%, and the over-the-counter, which act like generics, are about 5%, so 88% are generic-like. And then there's less than 2% that I haven't shown here called specialty drugs. Now, I didn't put them on this scale because, I'll put it on the next scale, it actually changes the scale dramatically. Okay, this is still the same patented brand at $859, but now a specialty drug per month costs over $6,000. Now this one, if you annualize it, now we're talking $75,000 a year for a chronic specialty medication. That would be like the university giving their employees a brand new luxury car each year. Now, do we do that, Jim? Did you get your new car?
Wait.
Yeah? You're waiting for it, huh? There is a long waiting list for the new car. Unfortunately, nobody's getting them. And I'm not saying that's good or bad, but we need to put these in perspective to other things in our economy and our society. These medications cost as much as nice brand new cars. We might give people a better deal on their light rail pass, but we don't give them a brand new Mercedes-Benz or a little sports car to drive around the university. So drugs and costs are a major issue. The next thing I would point out is the pharmaceutical market is shifting. Let me talk to this quickly, but at the university, first look at the blue bars. At the university, we provide a very generous, comprehensive healthcare plan for our employees, and probably less cost share than most plans. Our drug cost share is less than 8%, or about 8% of the drug cost. Most employers, the drug cost share is in the range of 15 to 20%. So we offer a good plan, but look at the blue boxes. These are pharmacy benefits delivered through a contract with a pharmacy benefit manager. And the blue on the left, PBM Traditional, is our retail network of pharmacies. We spend $26.1 million on drugs through retail pharmacy networks. The second blue bar is the specialty meds I talked about that we pay for through a specialty pharmacy. Most PBMs want you to use their own specialty pharmacy, their own specialty pharmacy that they make profit on. It's their profit center. We did not do that. We contract with Fairview Specialty Services, not because they're related to the university, but because we got the best deal from them, and in terms of quality of care, in terms of convenience and access for our consumers, and reasonable prices. But the point is, specialty drugs now consume $28.9 million. In other words, we're spending more on specialty drugs than we do on drugs in the retail outpatient networks. So as you talk about drug prices, yes, the drugstore is still important. We shouldn't ignore it. But all the money now is over in the specialty, and the fastest growing part is this second blue bar, the community specialties. But I also want to point out that remember our first slide, the pie? Not all drugs are paid for in the pharmacy benefit at all. Drugs are also paid for in the medical benefit on J codes and HCPCS codes, and a part of a visit to a physician's clinic or part of an outpatient hospital clinic visit. And I now get the data from our medical benefit and look at the drug spend. We spent, estimated for 2019, $14 million in medical specialty drugs, and then about $8.2 million in other drugs in the medical office. The other medical drugs are things like vaccinations. Some people still go to the doctor in case and get a vitamin B12 injection, or if you have stitches or surgical procedure, they might use antibiotic or lidocaine or anesthetic of some type. So there are a lot of drugs like that that are small items, don't cost a lot, not a big deal. But the specialty drugs are the fastest growing part of expenditures on the medical side. Soon, if you add together the specialty drugs, both the PBM and the medical specialty, those two together are up around 52, 55 million, and they're over half of our total drug spend at the university. So specialty drugs, 1.6% of the prescriptions account for half of all the spend out there today. That's going to be the same in a Medicare for all system. Yes, sir?
Could you just give a couple examples of specialty drugs?
Sure. Specialty drugs you get in the doctor's office might be Humira. You see heavily advertised on TV that's used for everything from psoriasis to rheumatoid arthritis to irritable bowel syndrome. So Humira is one. Remicade is another one used for rheumatoid arthritis. Many of the oncology agents, Avastin, Opdivo, Keytruda. Opdivo is the one that advertises on TV. Would you like a chance at living longer? I probably should just give you the Minnesota lottery number at the bottom there. Because Opdivo, I don't want to overly diss it. We found a new drug, it does have some effect. But this is a drug that extends life about 3 months, 3 to 4 months, at a cost of about $250,000 to $300,000. So, and the 2 to 3 months, that 3 to 4 months that you have is usually laying in the same hospital bed with the same tubes, and you just lay there longer. We as a society haven't dealt with valuing and paying for and the role of drugs like that. If you want to pay cash out of your pocket for that, you're welcome to do so. Should that be a part of our broader insured benefit? I don't think we've rationally evaluated that. And I'm not saying what the answer is, but we don't deal with that very well. Yes?
Do you know what the profit margin is on the specialty drugs?
Huge. Probably each drug is different and unique, but it's probably in the range of 80 to 95%. The total profit margin. Now, they do spend some of that on advertising, of course. Here's one thing. I study prices around the world. I travel to many countries, and every time I go to a new country, if I have time at all, I'll seek out and go into a pharmacy. I'll introduce myself, I'll ask for the head pharmacist and introduce myself and say, I study drug prices around the world. Would you mind to share with me how much, and I have a list of drugs, how much these drugs cost your patients. And then I say, would you mind to share with me how much they cost you? And I compare these prices around the world. And, overall, as you know, prices in every other developed country around the world are less than ours, and usually substantially less than our prices. And one of the things, in general, and actually this has gotten worse, it used to be our prices were about double what the prices in Europe are. But actually it's gotten worse. We're nearly 3 times the prices of drugs in many drugs in Europe these days. But when you break it down, there are a lot of reasons. One is there's a higher price in these other countries because they have a national health system. Imagine that. Anybody ever thought about that before? And they have a single organized system, and they make a decision about coverage of the drug. Will this drug be covered in the system? They may say, no, it's not covered, and the consumers still have a choice. We'll let them have that choice. If they want to pay out of their own bank account for a non-covered drug that isn't rational, we'll let them do that. But that's a different kind of choice than choice within the system. So naturally, they make a coverage decision, then they make a reimbursement decision, how much will we pay for that drug? And again, they allow the consumer choice. If it's, they'll say, we'll reimburse up to this amount. If you still want the more expensive, less effective drug, you're welcome to pay for it. That's a choice that I think a system could tolerate. But if it's an essential drug and the best therapy we have for something, it shouldn't be about a choice. It should be, is that covered and is it paid for? So we can do that. The point I was going to get to, though, is I look at the prices back when the U.S. was double the European prices. About half of that difference was made up because of the advertising costs. We have direct-to-consumer advertising in the U.S. No other country except for New Zealand also does that. And so I think that the advertising cost adds 20 to 25% additional cost to our drugs in the U.S. Now, if I went to my patients as a pharmacist and said, now, would you like that with or without advertising? And without advertising, it'll cost you 25% less. Which would you choose? Without. You don't think those ads are entertaining? Yeah, okay. But we don't have a choice about that advertising, do we? That's another place we might want choice. Do we want advertising with our drugs at the cost of a 25% increase? That's a choice I think many people would say, no, I don't want. I think most people would say, no, I don't want. But we're not given that choice. It's forced upon us. It's built into the cost of the drug, and we don't have an alternative. Yes?
Where does insulin fit into that?
Into here?
Yeah.
Insulin would be PBM traditional because keep in mind, this is where things get muddled with terminology and history of time. Insulin's been around since the 1930s. It is a biological before we ever had a category called biologicals. It's been in the market that whole time, and it's been treated. In fact, insulin, the original insulin, is not even a prescription drug. It's an over-the-counter drug. Okay, the original pure insulin. Now, most of the newer forms of insulin have been made prescription drugs. So insulin is really an OTC in the far left blue bar. The FDA, since now we do define biologicals as a type of drug, and we have a separate process, a biological license application for applying for biologicals, FDA has now announced that there are some old drugs that are truly biologics that they're going to move into the biologic category in the future. Opportunities that creates for creative pricing by drug companies. You get my drift, okay? So I'm excited by the change, but I'm a little bit nervous. One thing I comment, I'm truly not against drug companies, but their behavior tells us who they are. One thing I would say is drug companies are very innovative, and occasionally they find new drugs. Innovative in pricing, innovative in marketing, innovative in how they sell us things. The other thing is, I also have to give them credit. Drug companies, like this, spend a lot on R&D, both Republicans and Democrats. I'll have to tell you my other. I've studied this market for so long in public policy options, and I think we're making progress and there's hope, and then there's a setback. If you think about it, I think drug prices and gun control are a lot alike. And I don't care what your view is on gun control, but when we have a major shooting and people die unnecessarily because of guns. There are hearings in Congress. It's all over the news. Everybody's up in arms, pardon the pun. Everybody's angry about it. And a lot's said and done, but the policy doesn't change. When we have drug price issues, EpiPen goes up 700% over 6 years. We have insulin prices go up about the same over 6 or 7 years. We have people dying because they can't get drugs that are on the market. People get angry, frustrated. It's all over the news. Same thing, policies don't change. I really think both of these categories are examples of our captured legislature. They are captured by the way we finance money, the way we finance campaigns. Citizens United is an issue that needs to be dealt with. We may not make progress on these till we get rid of Citizens United. I think they are tied. Again, guns and drugs don't have to be tied in any other way, but politically they behave the same. In other words, we don't get anywhere because politicians are. Of course, those campaign donations don't affect their vote. Okay? They don't affect their vote. But somebody else tells them how to vote anyway.
Question. R&D versus advertising. Are they equal, or how much do they spend on R&D versus advertising?
It varies across companies, but in general, drug companies spend more on advertising than on R&D. And you'll also hear drug companies use the phrase, we reinvest our profits in R&D. As if all of the profits they make go back to research and development. No, they spend maybe 15 to 20% on R&D. And that's before they take out their profits of 15 to 20%. So profits in R&D are about the same, and they don't replace each other. That's double, right? And then the marketing advertising is even more than that.
Misleading?
Misleading, yes. What is misleading?
We reinvest our...
Oh, reinvest our profits in R&D. Yeah, that's totally misleading, or even not true. Yeah, it may be false.
Are we getting totally off track?
I'm totally off track, but I'm having fun.
So when we're in R&D, the issue comes up, a lot of the R&D goes on at universities.
Absolutely.
Right, and then how does that transfer happen? And do universities come out whole on that? Or that's a big topic.
Yeah, a couple of stories related to that. One, not all, but a lot of the university R&D is funded by National Institutes of Health or other government programs, Department of Defense, CMS, and other National Science Foundation. And universities do find things. In fact, almost all major brand name drugs, major breakthrough drugs we've had in the last decade had a substantial amount of their funding through government grants. Second, I'll tell you a story. One of my colleagues, a guy named Bob Vince, he's a professor in medicinal chemistry within the pharmacy school, he discovered a drug called Ziatin, or abacavir. It's for AIDS. It's effective. It was a very widely used drug. And he applied for, and the university applied for, got a patent on the drug. And they realized they can never market it, that they need to license it out to a drug company. So they first licensed it to Burroughs Wellcome. And Burroughs Wellcome then got bought up by GlaxoSmithKline, who then acquired the rights to it. And since GlaxoSmithKline already had some AIDS drugs on the market, they sat on it for about 7 or 8 years before they did anything with it. That's the first thing that's troubling. And then when they were ready to start marketing it and making it, they made it in a plant in Ireland. And they sent a notice to the university, since you only have a US patent, we don't feel we owe you any royalties. Okay? Now the university disagreed with them, and we took them to court, and the university did get royalties back on the drug. But that drug also was priced using the normal US model. The university had no say in how it was priced or how it was put out there, and priced at the usual high price margins that we see in the US, rather than what it would have cost in Ireland or England or other countries. So the drug companies will argue we want to protect intellectual property rights. but they don't really mean that. Did they protect the university's intellectual property right when they said we're going to make it in Ireland? No, they want to protect their intellectual property rights, not yours. I think patents and intellectual property rights are an area we need to pay more attention to. We allow drug companies to patent things that aren't new and novel, and we still call them new and novel. What is the purple pill? I say, what comes to mind? Okay, that's true today. What was the purple pill 10 years ago, 15 years ago? Prilosec was the original purple pill. Prilosec was a molecule called omeprazole. Omeprazole is a chemical that has right and left-handed versions. Omeprazole has both, a racemic mixture. And when omeprazole was ready to lose its patent, the drug company said, you know, we can split the right and left-handed versions, and we'll call the right-handed versions S-omeprazole, and we'll get a new patent and a new trade name called Nexium. So they've had 2 patent lives on that product because the patent office gave them a patent on S-omeprazole. Now, they're only supposed to give patents if it's new and novel. How could we have possibly known that omeprazole was on the market without knowing that it had right and left-handed versions? We knew that. It was in the literature, but the patent office gave them a patent on something that should never have been patented in the first place. I've talked with very well experienced patent attorneys who say probably more than half of the prescription drugs in the U.S. market that get patents should never have been patented because they really weren't new and novel inventions and shouldn't, and therefore shouldn't have been at the patented prices that we see in the marketplace. So patents alone, and then keep in mind today with biologicals and with new drug products, it's not just one patent on that little purple pill. We see the biologic products have what we call a patent thicket. They have anywhere from 5, 10, 15, up to, I've seen as high as over 250 patents on a single pill. 250 different patents. And they don't run all at the same time. They run sequentially and independently. And so patent lives could end up being these days not 5, 10, 15 years like the drug companies say they get, but they could actually be 20, 25, 30, 35 years. So when you hear them talking about the short time we get on the market and short patents, hold up the misleading untrue.
That's probably.
Yeah. Yes, ma'am.
Why do we need marketing and advertising of the drug? Is this to the physicians?
So who said we need it?
a lot of people, I've heard about private companies too, developing some pharmaceuticals and stuff.
We don't really need it.
We can't possibly market, so we sell it to the marketers and advertisers.
There are a lot of reasons. One, I tracked the number of prescription drugs prescribed per person per year, and it was going along like this. And then when direct-to-consumer advertising came into being, it went up dramatically. We allow this direct-to-consumer advertising partly because the U.S., they argue, is freedom of speech and they have a right to advertise. But do we need it? No. In the healthcare system, how often does the patient determine the drug they get? Can you write your own prescriptions? No, not legally, unless you're a physician. And then you have a fool for a patient if you write your own prescriptions. But other than that, we don't write the prescriptions. But here's how advertising has really been used. When we have healthcare systems that try to manage the market and use the resources wisely and say these are the best drugs and these are not so good drugs, and so we're going to not put these on the formulary, we'll put these on the formulary. Often the advertising is targeted in markets where the drug they're advertising is not on the formularies of most of the plans in that area. And they push it trying to get the doc to write or say dispense as written, or the patient to go in and demand, I want that Opdivo, I want a chance at living longer. Which is, we all want that, but at what price, and is it the right drug clinically and safety-wise and effectiveness-wise? So a lot of times the advertising is a way to circumvent the attempts to manage the drug benefit by managed care plans. If we, again, had a, imagine that, a national health system, I think it could change that dynamic, and I think it would be easier to say, let's just get rid of direct-to-consumer advertising. I would encourage elimination of direct-to-consumer advertising as one of the issues related to Medicare for all or healthcare for all. Yes, sir.
There was a time when they weren't allowed to advertise.
There was, well,
it wasn't too long ago, but I have another question.
That's partially true. I would call that a misleading. Not because you want to mislead us, but what actually happened up until 1997, technically drug companies could advertise, but they had to give fair balance on TV. And the definition of fair balance for TV ads would have required about a 5-minute spot in order to tell everything you need to for the fair balance. And during the Super Bowl, a 5-minute spot was too expensive, so they didn't advertise. In 1997, the FDA changed their criteria of what they would accept as fair balance, and they made it so simple that drug companies could do it in 1 minute or less, and then put their spots on primetime TV during the evening news, during the Super Bowl. So technically, you could have advertised before, but it was practically impossible. Then they changed the rules so it was practically possible. But how many of you ever remember anything about those drug ads in terms of the safety or the adverse effects? You know, they tell you running through the field, and then they say, you know, may cause death, flatulence, and other things. You don't hear those things. They're written in a way that you don't pay attention to the important things. The fair balance. So the fair balance changed, even though it technically was legal. Functionally, it didn't happen.
You mentioned in the previous chart generic versus off-patent and patent. What's the difference between generic and off-patent, and what's the interplay between pharmaceutical companies and generic providers where they can regulate or negotiate prices for production for generics?
Okay, they do. So off-patent, the second part of that's really important, off-patent brands. An off-patent brand, the patented brand, when it loses its patent and a generic enters the market, the original patented brand becomes the off-patent brand. So it's still the original brand name. The original brand names in the pharmaceutical market, rarely, if ever, does the original brand name compete on price. They don't lower price. Drug prices are what I would call sticky. They go up, they never come down. Now, generic prices do come down sometimes, and I think we have a true form of competition when a sufficient number of generics enter the market. But 1 or 2 generics is not sufficient. It takes anywhere from 4 or 5 up to 7 or 10 generics in the market to be truly price competitive. There are all kinds of games. Like I said, drug companies are very innovative. One thing is they've created this term authorized generic. Have you ever heard that term, authorized generic? Well, when a brand name is ready to lose its patent, about 3 months before it will lose its patent, the original company, either themselves will contract for a generic to be made and sell it under the generic name, or they will license out to a generic company to market a version and come on the market under their original application before any other generic can come on the marketplace. And then they come on the marketplace in a way that they capture the lion's share of the market. When the large chains have generics enter the market, they have to have generics in their pharmacies day one when the generics hit, because the pharmacy benefit managers are going to require a generic. And so first, by putting out the authorized generic, they get what we call filling the pipeline effect. They get to send 1 bottle to every pharmacy in the country. That alone is a significant amount of sales. And then when the chains realize that's the only one we have for a couple of months, we need to stock enough of that. And when a chain stocks a new generic in their pharmacy, they don't want to be changing brand of generic every month. Imagine if you came into the pharmacy and I give you a blue pill this month, and a green pill next month, and a pink pill the next month, and a purple pill the next month, pretty soon you're going to start to think, did they make a mistake? Is this the right drug? Is this really the same thing? Now, it may be the same thing, but the chains and the pharmacies know that that's confusing to patients to be changing the look of that drug every month. So they buy that authorized generic and they usually keep it in stock for a year. So that shuts out, that takes the market away from other true generics that want to come in the market and compete. So again, the brand names have found a way to kind of take the profitability out of generics entering the market by coming out with their own generic, not before they have to, but at the last 1 or 2, 3 months. And they'll come in the marketplace and take that market away. I think the practice should be outlawed. I think we should not use the term authorized generic. Yes, it's authorized, but it's not generic. And who's setting the price? The same brand name company that's setting the high price in the first place. Is that a market? Is that the way markets work? No, it's not really.
Isn't there some tendency also for the big pharma to buy up the generic manufacturers and then kick the price?
Well, first of all, there's been consolidation in the generic industry in general. And then you might have one generic company who actually had a branded product called EpiPen. Who was that? Mylan. Mylan is now the subject of a takeover bid from Pfizer. Is Pfizer a generic company? No. Well, think carefully. Yes, they are. They're a brand name company. They're one of the old school big brand name companies. I like Pfizer. They've done a lot of good things for us. But Pfizer has had a generic division called Greenstone for decades, and now they're buying the second largest generic company in the US market. So while in some ways, I do this and others do this in policy, we talk about brand name companies and generic companies, these days they're kind of one and the same. Also think about the largest generic company, Teva, an Israeli-based company. It's not particularly relevant to this, but Teva is the largest generic company. Their biggest product, though, these days was Copaxone. Copaxone is a brand name used for multiple sclerosis. So we have the largest generic company becoming more of a brand name company, and we have the second largest generic company being bought out by the largest brand name company. So it's kind of incestuous, isn't it? It's kind of, so we're seeing consolidation of generic companies, and if we only have 7 or 8 major generic companies in the first place, and they don't enter all markets, what happens to that competition we talked about? Remember, the number of firms affects the level of competition. So we're seeing consolidation and a lot less price competition among generics.
So they're not using antitrust laws.
There are nibbles at the corners. I've been an expert about 90 times in various lawsuits, fraud lawsuits, antitrust lawsuits, other things. There are some things that antitrust laws have been used, but they're not using antitrust laws. I haven't seen a decision on whether they're going to let Pfizer acquire Mylan. I would argue that if anything screamed for antitrust prohibition, that one does, although I don't know what's going to happen. There's some other trends I see that are equally troubling, and it doesn't diminish the trouble of that one. Another trouble, you know, we hear about disruptive behaviors in the marketplace. It's kind of how things change. And some disruptions can be positive and good, some can be negative. One of the biggest disruptors in the healthcare and pharmaceutical marketplace is what we call vertical integration. We have, there are three big examples. So we have a company called CVS Health, CVS Stores. And CVS and Caremark merged. And so you have a retail network of pharmacies now merged with a PBM. Remember, the PBMs were there to help make sure we don't overpay for drugs at the retail level. And so now you have one of the largest PBMs buying the largest network of retail pharmacies. And then those two, CVS Caremark, now have bought Aetna, an insurance company. And so this is vertical integration. You have the insurance company who then sends all of their patients to Caremark Aetna, sends all their patients to Caremark PBM, who try to send all their patients to CVS pharmacies. Now that would be good if the CVS pharmacies had the lowest price in the market. Do they?
Yeah.
No? Let's like look at some real data here. I've got a slide on that. I'm going to just jump off the slides and selectively show you things because I like the questions and dialogues better. But let me show you what happens with that. So I work with consumer reports. In general, consumer reports is pretty dependable, reliable. You know, when you go buy a new car, you look it up in consumer reports. So you go buy a new refrigerator, you check out. Well, we took 5 generic drugs that are commonly used, and the folks at Consumer Reports went to 6 metropolitan areas around the country, 6 different areas. And they went to every pharmacy in those metropolitan areas and priced those 5 drugs and said, how much does this set of 5 drugs cost? And then they showed the results by type of pharmacy. Now, notice over here, Health Warehouse and Internet, Science, Costco, and independent pharmacies and Sam's Club all cost $200 or less for that 5 generic package. And then Target, which no longer exists, they were bought out by CVS. And then Walmart, Kmart are kind of in the $300 to $500 range. But CVS that Aetna's going to tell you to go to, is that the best deal you can get for a drug in the community? No, that 5 drugs cost you $800. Nearly 10 times what the internet site does and more than 5 times what the Steve's Corner drugstore would cost. We think when a PBM sends us to a preferred pharmacy that means it's a better deal, right? Have you been sent to preferred networks of physicians and pharmacists? I don't know about the physician market, but I know the drug market. And preferred networks are preferred by the chains and the PBMs, not by the consumers. Okay? So pay attention to those. Preferred doesn't mean cheaper for anyone. It means higher cost. And my fear is vertical integration. When I own the insurer, the PBM, and the retail chain of pharmacies, I could send all the patients to my pharmacies and charge what I want. In fact, the data shows us that's what they do. I don't like vertical integration. Vertical integration is like some of the advantages of a single payer system, but it's going to be a 4 or 5 payer system, and it's outside of the oversight of the government, so they can do whatever mischief they want, and you have to chase us with antitrust laws. And we can tie you up in court as long as you want to fight. And they do. I don't like vertical integration. So it's not just Caremark, CVS, Aetna. Think about in our own market. The Blues own Prime Therapeutics, a PBM. It's a decent PBM. And they're partnered with, in a joint venture with Walgreens. Same kind of vertical integration in the insurance company, Blue Cross Blue Shield. PBM, Prime Therapeutics. Retail pharmacy, Walgreens. Walgreens prescriptions cost more than the same prescriptions in other pharmacies in that network. Again, the preferred pharmacy isn't a better deal for you as a consumer. And then I can tell you Express Scripts, and there are others out there. Now Humana and Walmart Humana is a PBM insurer and Walmart is a large chain. They don't have dance partners yet, so we'll have to see kind of if they're going to line them together or create an alternative. But I'm very fearful of, and I haven't seen the antitrust laws used to prohibit vertical integration. I think it's a very dangerous practice in terms of quality of care, in terms of cost of care. I think it will continue to drive costs up even faster.
What did you say? Express Scripts, how's that fit in? It's not a...
It's a PBM.
It's a PBM.
Just like Caremark is. A PBM is the one that the university has to hire a PBM to run our drug benefit. I can't process all 300,000 prescriptions that come in.
How do they sort of fit into all this? Because they sell directly.
The PBM?
No, Express Scripts. I buy.
Oh, you buy as a mail order?
Yeah.
Yeah, but so here's what happens. If they're aligned with an insurer, they are now Cigna, if they're aligned with an insurer, they'll say you have to get your prescriptions through mail order, and you have to use Express Scripts mail order. And by the way, that'll be $800 for your prescriptions, not $136, and you don't have any choice. And since it's insured, you don't even see the $800. You may have an out-of-pocket that's lower, and you think, well, if it's not out-of-pocket, it doesn't concern me. Premiums are an out-of-pocket cost too. So don't forget that will add to your premiums. The $800 bumps your premiums up. We wonder why healthcare premiums are going up. It's not because of the Affordable Care Act. It's because there are behaviors going on in the market that everybody's adding to the cost behind the scenes, not on the out-of-pocket side, but on the back side, and that drives up the experience rating and the cost of the premium the next year. So I always have to remind my students, healthcare is not a free benefit. And we've kind of developed this mentality that healthcare is a free benefit. Or even I've heard healthcare providers, physicians, pharmacists, nurses say, oh, they have insurance, don't worry about the cost. Well, you should worry about the cost because, again, it drives up the premium in the long run. So healthcare is not a free benefit, and insurance companies do not pay for any healthcare. Here's another thing I've learned. I worked a lot with the Minnesota Health Action Group, which is large employers in the state, and they very carefully trained and cautioned me who is a payer and who is not. Is Blue Cross Blue Shield a payer for healthcare? No. Not really. They process transactions. Is Cigna, is Aetna a payer? No. Is even a large health system, is Health Partners a payer? No. They're not a payer, they process transactions. The only payers are employers who pay for your health premium in lieu of more salary. Did you want more salary or health benefits? Well, often we take the health benefit because it has taxable privileges that reduce the cost of our income. So employers, individuals who pay for their own health care out of pocket are payers. And the government, and ultimately, who's the payer for the government? You, the taxpayer. So it all, whether it's an employer or a government or a self-insured patient, it all comes back to you. Healthcare comes out of your pocket no matter which approach we use. It'd be nice if we had a common system, wouldn't it?
Yeah.
Can you imagine that?
Yeah.
I wouldn't want to preach to the choir.
So last week, Health Partners announced they're closing their pharmacies. So how does that fit into this?
I'm glad you brought that up. I was going to mention that. Health Partners has closed they will, next spring, close 30 pharmacies, all of their retail pharmacy outlets. They said they will keep their specialty pharmacy. I don't remember what they said about their mail order. They were keeping it closed. I think they're closing that too. So they're only keeping their specialty pharmacy. Yeah. Can we shut that off for a minute? The taping it?
Oh.
Oh.
Yeah.
Oh.
All right. The recording too then.
Edit. They also are valuable, and they compete in sort of a branded sense and give us alternatives. And sometimes we find the second or third version is actually safer or more effective. So in that context, Me Too, the context of Me Too that is a nuisance, and I'll give you a real example. I'm completely HIPAA compliant. I never know patient identities, but I review every one of the 330,000 prescriptions that comes in at the University of Minnesota and look at pricing and patterns and issues like that. And so in October of 2016, I remember reviewing the prescriptions for the month, and I saw pop up on the screen a prescription for Zegrid. Zegrid is omeprazole and sodium bicarbonate. Now, sodium bicarbonate is really expensive. You know what I mean, you know, Arm & Hammer, you know. Thank you, so yeah. And omeprazole was generic by that too. The purple pill was the first one, was generic. It came through in a 90-day supply. The amount that we were billed and charged was $17,000. What? And the PBM approved it, and we paid it. I literally almost fell out of my chair. And then I thought, oh my God. are there others like this? And I looked and I found there were like 8 or 10 of these already before I caught it. So it had already cost us over $150,000. When I looked at it, there was a company called Valiant. Valiant's a Canadian company, but it was run by former CEOs or former executives from big American drug companies you would recognize. And this is a company that, for the most part, goes out and buys old, off-patent brand name drugs, and then they market them and jack the price up tens, hundreds, and thousands of %. And they aren't doing any research and development. They do a lot of the R&D of Republicans and Democrats, but they aren't doing any research and development. So these are what I would call, there are some companies, drug companies, that truly are still doing research and development to find new therapies. And we can look at those and judge, are they good or bad at it? And even the bad ones don't get driven out of the market. But there's a new class of companies that just blatantly aren't trying at all to find new drugs, but they're extracting capital out of healthcare by charging $17,000 when the generic equivalents of those could have been purchased for under $10 instead of $17,000. The university spent over $150,000 when we could have spent under $200. That's taking capital out of the market and out of the healthcare system that isn't improving anybody's health except for the financial health of the shareholders of Valiant. Now, Valiant has disappeared from the market, not for good. They changed their name. It's called Bausch now, B-A-U-S-C-H. And there are 2 or 3 other companies that have the same game plan. Let's buy old products, jack the price up dramatically, and they know that it'll go through the system. The PBMs they pay the PBMs really high rebates. So the PBMs are happy. And the PBMs could say, we're giving you more rebate money back. Isn't that a good thing? Didn't you want more rebates? We'll give you more rebates. It'll cost you $17,000 up front, but we'll give you half of that in the rebate. Look at it, look how much rebate you're getting. Isn't that one? And we're giving you a bigger discount too. It's a 50% discount. I'm serious. This is the way the game works. This market is perverse. It's just terrible. Yes.
Are generic right purchase, or can any company just decide they're going to produce a generic? Is there real competition?
Well, it's neither of those exactly. Once a patent has expired on the molecule of the drug, then other companies could apply to FDA to make it. But first they have to develop the product. They have to go through testing to make sure that their drug delivers the same amount in the bloodstream as the original product did, and that it would be generically equivalent. We have an FDA that assures that generics are exact equivalents of that brand name. And if they meet those criteria, and it usually takes a company 2 to 3 years to do the testing to do that. So you can't, it's not immediate, you can just jump in the market, but you can, if you do the 2 to 3 years of work, then you can apply to FDA for an abbreviated new drug application and get approved on the market. But the drug company may have a patent not just on the molecule, but on the dosage form or the sustained release form or on the auto-injector used to give the epinephrine. So they get patents on other things that block you other than the molecule. But if you get past all that, yes. If a drug company is overcharging for a given drug, competition may eventually come in the marketplace, but it takes 2 to 3 years at a minimum. So that creates what I would call a functional monopoly in the marketplace, even when all the patents are gone. Because if I know I have 2 to 3 years before a competitor can be approved on the market, I can charge what I want for 2 to 3 years, laugh all the way to the bank, and I can exit the market in 3 years when the generics come. So that's what, remember Martin Shkreli, the kind of sleazy Wall Street guy that marketed Daraprim and charged a whole lot? That was a product that was technically off patent, but he knew it would take 2 to 3 years before a generic could come, and so he just went ahead and did it. So we see behaviors like that. For good reasons, we have regulatory barriers to generics just entering the market tomorrow, because we want it to be a safe and good quality product. But that slows down the market and changes the competition dynamic too. Well, other questions?
Say we reformed the whole system and you know, had control of what is happening right now. What would the research on new products change at all, or is, you know, I keep thinking about, you know, there's always a need for new stuff out there.
Yeah.
And so what kind of impact does that have?
Well, I think that's an issue. If we made the changes that you guys are thinking about in healthcare, we'll have to be careful in the pharmaceutical market and manage it carefully. You could do harm, but you could do great benefit. It's like anything, you know. The nuclear technology we had has provided great benefit in some sectors, but it also caused harm and death to a lot of people. Things can be used for good or bad. Healthcare for all can be used for good or bad. It can be done in a, you know, governments can do it very poorly. There are governments that don't do well, but they can also do it very well. Depends on, you know, accountability. So research and development, finding new drugs. We would need to continue investing in NIH type funds and finding new drugs. Another story I like to tell is if you think of cancer drugs and you think of drug companies that make the most cancer drugs, how many here are nurses, physicians, pharmacists? Which drug companies come to mind in terms of making cancer drugs with the most cancer drugs? I think of one, 3 initials, BMS. Who would that be? Bristol Myers Squibb. About a decade ago, I looked at Bristol Myers Squibb had more cancer drugs on the market than any other drug company. And so I wanted to say, okay, so how much was paid for by government or other things, and how much did they discover? And I looked, and they had like 25 molecules on the market. How many of those molecules did they discover with their own research and development?
0.
0. None. All of the cancer drugs that they were marketing had been discovered outside and licensed in. And in fact, the majority of them have been discovered with funds from NIH, National Institutes of Health. And who was the research director at Bristol Myers Squibb at the time? The former director of the NIH. You get the picture? In pharmaceuticals, we have this thing called a revolving door. In all of the policy world, the revolving door is, yeah, you work for the government for a few years, and then you get a cushy job at a drug company. You work for FDA for a few years, you get a cushy job at a drug company. You work for the Department of Trade and Commerce that negotiates free trade agreements, then you get a drug company job after that. Yes, ma'am.
So, how much money the CDC gets for research? Case example is the amount of money that like HIV and AIDS gets versus Lyme disease. There's more Lyme disease cases every year.
So the question, who decides how much money goes into research and where it goes? It's kind of a multi-layer process. On the big picture scale, Congress sets an amount, an appropriation amount for CDC or for NIH. But within the amount that NIH or CDC or FDA or other government agencies get, then they make decisions within that. So some of it's at the legislative, political level, and some's at the regulatory, bureaucratic level within the Bureau. So some of both. Now, certainly if one lobbied Congress and members of Congress, you could get them to do what we call earmark or specify certain amounts of increase in this area or that area. But it's a multi-layered decision process. And it's hard to change those individual amounts over time. Yes.
So what is the percentage of drugs that are actually discovered by government-funded institutions as opposed to those that are discovered by drug companies? In other words, how much tax dollars are actually going into research and development compared to what happens in the drug company?
Well, let me, a couple of quips and then I'll try to answer your question.
Okay.
Most drugs are discovered before the drug company finds out about them. Okay? And often by the NIH. I forget the numbers, but somebody looked at the last 10 years of all new drugs coming on the market, and all or nearly all of them had NIH funds as a part of it. Sometimes it's hard to isolate who really discovered it, and it was funded from multiple sources, so it's hard. But NIH was almost always a part of it. Less than half of the drugs that apply for a patent, the patent holder who is applying for the patent is not the one who discovered it less than half the time. And if new drugs approved by the FDA, less than half of the time is the company applying for the new drug application is not the discoverer of the drug. They bought the rights in from somebody else, and they're then appropriating it. Some people argue, addressing the AIDS crisis in Africa, and the Bill Gates Commission came in and said, would be better off just to buy the patent rights to these HIV drugs and then sell them at cost of production, like a nickel a tablet in Africa. Some have argued would be better off in the US to do that too. When NIH discovers things, have NIH keep the rights to those drugs, in contract with somebody to market it, but don't give it off to the drug company at a bargain rate and then let Bristol Myers turn around and overcharge us for the cancer drugs we use, or some other company. Yes?
So, we're in the process of trying to figure out how much could be saved with Medicare for All. Based on your numbers, it looks like we're spending $700, $800 billion a year on drugs somewhere there.
Could be, yeah.
What do you think is a realistic estimate of what could be saved if we had the negotiating leverage?
Yeah, let me talk through some dynamics of that. And actually, I'm not sure we fully invented the idea, but I remember a conference with Senator Paul Wellstone, Representative Gil Gutnick, and myself, maybe 20 years ago. We proposed importation of drugs from other countries before it was talked about out there. We kind of put the idea out there. I think people sometimes oversimplify the role of importation. I think importation can help, but simply saying the prices are cheaper in Canada, let's just go buy them in Canada and bring them down here, won't work. And let me explain why it won't work. I'm not opposed to importation, but first of all, Canada has about 1/10 of the population that the US does. And the drug companies ship enough drug to Canada to meet the needs of Canadians. But if we started buying, if we authorized and said you can import from Canada, we started bringing drugs from Canada to the US, Canada would hear this big sucking sound to the south, and all their drugs going down there. And within a week, the Canadian Parliament will have had an emergency session and prohibited exported drugs to the US. It'll happen. So, first of all, it's not practical because Canada won't want that. It will greatly harm Canadians and their access to drugs. And secondly, the drug companies won't want it to happen. They won't ship enough drug to Canada to supply all of the US. They know. I'm saying. But I do think some level of importation with a broader set of communities, the European Union and Canada and Australia and New Zealand and Japan, some level of either reference pricing and or importation may bring about change. The way I would do importation is let's just pick a handful of really critical drugs and work with FDA to figure out how can we import it, and let's just go negotiate directly with the drug company. I think of insulins. I think of EpiPens. I think of naloxone, where we're dealing with the opioid crisis. I think of Truvada for the AIDS crisis. And we can add a Lyme disease drug in there. And those have been extremely expensive at times too. So we could just pick a handful of drugs and see if we can make the importation model work in a unique way. So that's one thing. Second, in negotiation of prices. Well, the other thing is the US, by dollar volume, not by unit volume, but by dollar volume, the US pays for a little more than half of the world's supply of drugs. So no matter who else we negotiate with and how much lower their price is, they're a smaller share of the market than we are. And so we can't find the smallest player in the market and say they get the lowest price, therefore the person that pays for 1% of the market gets a low price, let's apply that to 50% of the market. That won't happen either. It's going to be a balancing. In a sense, we're going to have to push the rest of the world and tell them, you're going to have to pay a little more for your drugs. We're tired of paying for all of your R&D and letting your free ride. I don't want to cause public health crises in other countries necessarily, but in some ways for us to get lower prices, there would be somewhat lower or higher prices in other countries. But also, I think we need in the U.S. to set, and I like the new bill, Rose, you sent me a new bill, just, who was that? Who proposed that? The new bill was proposed to set up a drug accountability agency. I think prescription drugs are 4% of the U.S. economy. Show me anything else that's 4% of our economy.
Booker and Sanders.
Sanders and Booker, yeah. There's nothing else that's 4% of the U.S. economy that doesn't have a government agency providing oversight on pricing. Everything else that's 4% of the economy, we have effective price accountability structures. I'm not saying beat up the drug companies. I'm not saying don't let them be profitable. I'm not saying don't reward them for innovation. But let's make sure the innovation we reward for is a new drug that cured more people, not a new drug that made $17,000 when it should have cost $10. That's not innovation. And yet we're rewarding that just as much as we are the new drugs in the marketplace. So our quote system for rewards and market is very, very ineffective and really results in these perverse behaviors that we're seeing. We're to blame for what we see in the market because we've let the market work that way. So I think we need this accountability agency that sets some standards and says, here's how we will assess how much you as a company really spend on research and development, not on Republicans and Democrats. We won't count that, and we won't give you any credit for spending on advertising, and we won't give you credit for lots of other, for buying in patents and licenses or coming up with new dosage forms that allow you to continue to charge patent prices. We won't count all of that in your price accounting. But if you show us what it costs, then we'll give you a reward for that innovation. We'll reward the rare disease drug, the true new therapy. We'll pay a really handsome price for that, and probably as high as they are now. But there are a lot of other drugs that we're overpaying for that we can change in the marketplace. And we can, remember Reagan, he had what he called trickle-down economics. I would argue the system we have in healthcare is trickle-out economics. That the money's flowing out everywhere except to the patient and to the payer. And we need to stop. We need to plug all the holes in the dike until it gets down to the patient and the payer these days. Money's trickling out too many places for things that aren't improving healthcare, and in fact, it's taking away from healthcare. So, how much? I don't know. I think we might be able to reduce the drug spend on the order of 20–25%. Probably on that order. I don't think we can get a 50% reduction.
I think some of the plans out there are assuming 50%.
Well, again, people look at, I look at VA prices. We have about 10 or 15 employees at the university that are veterans who qualify for VA benefits, and they're getting their prescriptions filled at VA, and so I see the amount that VA charges us, and they're really inexpensive. Their insulin cost is about 5% of what we have to pay normally. But that doesn't mean if we negotiate prices for the whole government that the whole government will be able to get VA prices for insulin. Because there's I think the VA gets lower than market-based prices for some good reasons. We would not have a finished dosage form pharmaceutical industry in the U.S. but for World War II and penicillins. Because when World War II came into play in surgical suites all across the war venues, they had infections, and we had discovered penicillins, but we couldn't mass produce them in the laboratories and universities and places enough to fill the need. And the major drug companies emerged out of that and helped us develop those finished dosage forms. They have, a few of them do have a sense of memory and a sense of decency at times. And I think they give much lower prices to VA because they know they wouldn't exist but for the money that the military and the government invested in them back in World War II and in the 1950s. So, but we won't get VA prices. VA doesn't get that lower price just because they're good negotiators. They are good negotiators, but we won't get that price market-wide. I think about a 20 to 25% reduction is a realistic target for savings in drugs with negotiation. But if you don't negotiate at all, don't expect any savings. I thank you for your time.
Awesome. Thank you.
Take